Hello, my name is Monica Piecyk. I'm a rheumatologist at England Baptist Hospital. I'll discuss joint pain, its differential diagnosis, ways to distinguish between these different etiologies, testing that can be helpful, and I'll present several cases to help illustrate these points. This is a schematic of a joint. So pathology in any of these structures within or around the joint can cause a patient to experience joint pain. The differential diagnosis of joint pain is broad, and this is by no means an all-inclusive list. Osteoarthritis is a common cause of joint pain. Inflammatory arthritis may be due to rheumatoid arthritis. Spondyloarthropathies include psoriatic arthritis, ankylosing spondylitis, and reactive arthritis. Gout and pseudogout are crystal-associated types of arthritis that typically cause episodic, acute, and sometimes severe joint pain. Polymyalgia rheumatica is an inflammatory disorder that tends to occur in older patients. In order for a patient to be diagnosed with a systemic autoimmune disease, they need to have something in addition to just joint pain. In patients with systemic lupus erythematosus, rashes and cytopenias are common. Sjogren's syndrome classically causes dry eyes and dry mouth, and most patients with scleroderma have severe Raynaud's and sclerodactyly. Hypermobility syndromes can cause joint pain, and this can be anything from a benign hypermobility syndrome to a defined Ehlers-Danlos syndrome. Fibromyalgia is a disorder in pain processing signals rather than pathology of the soft tissues or joints themselves. Other soft tissue syndromes include tendinitis and bursitis. Inflammatory muscle diseases and vasculitis can also cause joint pain. There are many systemic diseases to consider in the differential diagnosis of joint pain. Septic arthritis may be monoarticular or polyarticular. Infections can cause joint pain such as Lyme disease, parvovirus, hepatitis, and endocarditis. Many malignancies can be associated with joint pain, as can sarcoidosis, and endocrine abnormalities such as hyperparathyroidism or thyroid disease. In patients with obstructive sleep apnea who may not be getting restorative sleep, these patients can experience musculoskeletal pain as well. Medications should be considered in the differential diagnosis. HMG-CoA reductase inhibitors can cause myopathy and myalgias, and aromatase inhibitors that are used to treat women with breast cancer can also cause joint pain. The first case that I'd like to present is a 74-year-old woman with joint pain in her fingers. She reported a few-month history of hand pain that was worse in her left third distal interphalangeal joint and also at the base of her thumbs. Her symptoms were worse in the morning. She had difficulty with fine motor skills, such as opening jars and buttoning her clothes. She had noticed that her hands were going crooked, and she had swelling in her left third DIP joint. Her past medical history included COPD and a pulmonary embolism. Medications included anticoagulation with warfarin, so she had not taken any over-the-counter pain relievers because of this. And she had quit smoking 20 years previously. Her physical exam included a normal BMI. Her general physical exam was normal, and on musculoskeletal exam, she had squaring and crepitus of the carpometacarpal joints of the thumbs, with pain on the left with range of motion. She also had bony enlargement of the distal interphalangeal joints with mild swelling and tenderness of her left third DIP joint. So this is an example of a patient with osteoarthritis who also had swelling of a DIP joint, more severe than that seen in my patient. These are my patient's hand films, which are consistent with osteoarthritis. She has joint space narrowing, which is apparent in the DIP and PIP joints. She also has some joint space narrowing at the base of her thumbs, at the CMC joints. It's important to note that the MCP joints are spared and there are no erosions. Her carpal bones are also normal. Carpal bones are commonly affected in inflammatory arthritis. She also has a classic finding of osteoarthritis on X-ray. If you look at her left fourth DIP joint, due to joint space narrowing and osteophyte formation, she has what's termed a gull wing deformity, where the joint line takes on the appearance of a flying seagull. Treatment goals in osteoarthritis include decreasing symptoms, improving daily function, and it may be possible with weight loss and low-impact exercise to actually slow progression of osteoarthritis in the hip and the knee. Physical therapy is also helpful for many patients. One example of this is quadriceps strengthening exercises for patellofemoral osteoarthritis. Splinting can be helpful in certain patients. The scenario where I use this the most is in patients with osteoarthritis in the CMC joints of the thumbs. Nighttime splinting can be helpful for reducing their daytime symptoms. Acetaminophen and NSAIDs can also be helpful in patients. If a patient requires an NSAID on a daily, or requires daily dosing of an NSAID, then I also have them start a proton pump inhibitor in order to reduce their risk for gastrointestinal complications. Topical pain relievers that contain capsaicin can be helpful. These are tricky to use in hand osteoarthritis because it's important for the patient not to get this substance in their eyes. Topical NSAIDs can help some patients, and if a patient is using a topical NSAID, they should not also take an oral NSAID due to a risk of increased toxicity with the combination. The second patient is a 62-year-old woman who developed joint stiffness and swelling. She reported a 1-month history of diffuse finger stiffness that was worse in the mornings. She had noticed swelling in her index fingers as well as bilateral knee stiffness. She denied true joint pain or any erythema or warmth of her joints, and she denied systemic symptoms such as fatigue, fevers, rash, alopecia, oral or ocular dryness, Raynaud's, or muscle weakness. All helpful questions in a patient who presents with new joint pain. She had found that warm baths and low-dose ibuprofen were helpful in reducing her symptoms. So when thinking about a patient like this who presents with joint stiffness, how can you distinguish between an inflammatory and a non-inflammatory or osteoarthritis? The pain of inflammatory arthritis tends to improve with activity and is usually worse in the morning. There can be a sudden or gradual onset of symptoms in inflammatory arthritis. Patients often have increased joint stiffness and pain after periods of inactivity, such as sitting at a desk at work or after driving in a car. Patients may have extra-articular symptoms, such as fatigue, fever, weight loss, Raynaud's phenomenon, or symptoms of lung disease. And if a patient does have extra-articular symptoms, it's also important to consider malignancies and other systemic diseases. The hallmark of inflammatory arthritis on exam is synovitis, where the joint is swollen and feels boggy or spongy. There can be joint effusions, and if so, the joint is often warm, and there can be overlying erythema. In contrast, non-inflammatory arthritis improves with rest. There's usually a gradual onset of symptoms, and symptoms are usually worse later in the day after the patient has been active. Symptoms are isolated to the joint, so patients with osteoarthritis do not have extra-articular symptoms. Effusions can be present, but in this case, the joint is typically not warm and not erythematous. Crepitus is a characteristic finding of osteoarthritis. This is due to damage to the cartilage, and the joint has a grinding or sensation when moved. There can also be bony enlargement of joints, so the joints of osteoarthritis are not boggy as they are in inflammatory arthritis. On synovial fluid examination can be helpful in distinguishing the two. The cutoff for an inflammatory arthritis is greater than 2,000 white blood cells per cubic millimeter. The pattern of joint involvement differs between rheumatoid arthritis and osteoarthritis. Classic joint involvement in RA includes involvement of the MCP and PIP joints with sparing of the DIP joints. In contrast, in osteoarthritis, the PIP and DIP joints are involved with sparing of the MCP joints. It's also common for osteoarthritis to involve the base of the thumbs, the CMC joints. In rheumatoid arthritis, wrist and foot involvement is very common, and virtually any other joint can be involved with RA other than the thoracic and lumbar spine. Osteoarthritis commonly affects the knees and the hips, as well as the spine and the feet. And other joints are usually only involved if there's been a history of trauma to these joints, such as the shoulders or the elbows. This is a patient with osteoarthritis with classic bony enlargement of the DIP and PIP joints. Another term for these is Heberden's nodes for the DIP involvement and Bouchard's nodes at the PIP involvement. Rheumatoid arthritis is a different process. So there's synovial inflammation, which can lead to pannus formation that invades the cartilage in the bone, leading to bone erosions and potentially extensive joint damage. This is a patient with synovitis with a more fusiform, boggy or spongy swelling, most prominent at the PIP joints. This is a patient with rheumatoid arthritis with classic synovitis at the MCP joints, and a more extreme example of rheumatoid arthritis with subluxation at the MCP joints and the formation of rheumatoid nodules. So these are the changes that we're trying to prevent with early and aggressive treatment of rheumatoid arthritis. Radiographically, RA and OA can look differently. The joint space narrowing in RA tends to be symmetric, so the entire knee joint space is narrowed. Whereas in osteoarthritis, the joint involvement can be asymmetric. So in this patient, they have medial joint compartment narrowing with a normal lateral joint compartment. Bone loss is characteristic of rheumatoid arthritis, and erosion formation is often seen at the margins of the joints. In contrast, in osteoarthritis, bone formation occurs and osteophytes can form at the margins of the joints. So back to my patient, her past medical history included asthma, migraine headaches. She had a distant history of scleritis or eye inflammation. She was treated for breast cancer 16 years previously. She also had a history of reflux esophagitis, irritable bowel syndrome, and osteoporosis. Interestingly, 7 years previously, she had a few-month episode of finger swelling that she described as similar to what she was now experiencing. Her medications included low-dose ibuprofen, and she had quit smoking about 10 years ago. On physical exam, her general physical exam was normal. On musculoskeletal exam, she had mild soft tissue swelling between the MCP and PIP joints of the second fingers bilaterally. She did not have definite joint synovitis or joint tenderness on that first visit, and she had a normal range of motion. So in a patient like this who presents with prominent joint stiffness and who may have an inflammatory arthritis, testing can be helpful. CBC is helpful as anemia is common. Liver enzymes, creatinine, and urinalysis can also be helpful in sorting out what type of inflammatory arthritis this may be, as well as to exclude other etiologies. Inflammatory markers are helpful. Sedimentation rate and C-reactive protein are often elevated in patients with inflammatory arthritis, although not always. A rheumatoid factor is positive in 70 to 80% of patients with rheumatoid arthritis, but it has a very low specificity. Up to 10% of healthy people can have a positive rheumatoid factor. Other connective tissue diseases, such as lupus and Sjogren's syndrome, in these patients, they can also develop a positive rheumatoid factor, and false positives can be seen in paraproteinemias, hepatitis C, and other chronic infections. Cyclic citrullonated peptide, or CCP antibody, is positive in 50 to 70% of patients with rheumatoid arthritis, and the specificity is greater than 95%, so much higher than that of rheumatoid factor. In a patient in whom I'm suspecting possible inflammatory arthritis, I check both the rheumatoid factor and the CCP antibody. They are both helpful. A very high titer positive rheumatoid factor confers a worse prognosis. If a patient has other findings that suggest a possible ANA-associated autoimmune disease, such as systemic lupus, Sjogren's syndrome, scleroderma, or inflammatory myositis, then I also check an ANA. If a young woman presents with a new inflammatory arthritis, they should always have an ANA checked, as this is the peak age of onset of lupus. Lyme testing can be helpful, especially if a patient has isolated knee inflammatory arthritis. In late Lyme disease, the most common arthritic manifestation is an inflammatory effusion of the knee. Other large joints can sometimes be involved, but more diffuse arthralgias are typically seen only in early Lyme disease. So these lab tests can be helpful, but are not always diagnostic. As mentioned, there can be false positives, especially of the rheumatoid factor, and sedimentation rate can be caused by other etiologies. Hand, foot, and wrist radiographs are also helpful depending where the patient has had symptoms. Often early in disease, these will be normal, which is definitely a good thing. The first sign that develops on radiographs in a patient with inflammatory arthritis is osteopenia, which is typically periarticular. Bone erosions and joint space narrowing can be seen in patients with more advanced disease. So back to my patient, her laboratory data included a normal CBC, normal kidney and liver tests. Her urinalysis was normal. Her sedimentation rate was high at 73 and C-reactive protein high at 46. Rheumatoid factor was markedly high at 212. A normal is less than 14. And her CCP antibody was also very high at 182. A normal is less than 19. Her ANA was negative, and her parvovirus serology was consistent with past infection. These are her initial hand films, which are normal. There's no joint space narrowing, and there are no erosions. So this patient has rheumatoid arthritis. She presented with joint pain, stiffness, and swelling. At her second visit, she did have synovitis on exam with soft tissue swelling of the second through fifth fingers bilaterally and tenderness of the PIP joints. She also had this distant history of scleritis, which can be associated with rheumatoid arthritis. She had elevated inflammatory markers, including a sedimentation rate and C-reactive protein, and she had high titer positive rheumatoid factor and CCP antibodies, so highly suggestive of rheumatoid arthritis. She was started on methotrexate and prednisone, and she's done well and been able to taper off prednisone. So what are risk factors for rheumatoid arthritis and osteoarthritis? Rheumatoid arthritis is the most common chronic inflammatory arthritis. It affects about 1 in 100 people. 75% of those patients are women. The peak age of onset is between the 30s and 50s. Family history plays a role, although when an identical twin has rheumatoid arthritis, the chance of the other twin developing rheumatoid arthritis is only 1 in 3. Cigarette smoking is also a risk factor for the development of rheumatoid arthritis. Osteoarthritis is much more common. Knee osteoarthritis affects 1 in 2 people at some time during their lifetime. It's more common at an older age. Obesity is strongly linked to the development of knee osteoarthritis. Family history plays a role. I often see women with severe osteoarthritis in their hands who report a mother or grandmother who had similar findings. A prior joint injury increases the risk for later osteoarthritis in that joint, as does a joint deformity, such as a congenital hip dysplasia. The next patient is a 58-year-old woman who developed joint pain and weight loss. So she reported a 3-month history of hand and foot pain. Her pain began with pain in the balls of her feet when walking, and she had noticed swelling in her left foot. She also developed swelling in her fingers and MCP joints. 2 months ago, she was seen in an emergency room for left shoulder and arm pain. Shoulder x-rays and cardiac evaluation at that time were normal, and these symptoms resolved in 4 days with high-dose ibuprofen. She also had a many-year history of right hip pain, and when I first saw her, she was scheduled for a right total hip replacement. She reported prominent joint stiffness and difficulty making a fist, and her symptoms were all worse in the morning. During the past 3 months, she had lost 9 pounds. She had a marked increase in fatigue, finding that she needed more sleep, and she was unable to do a lot of the activities that she previously enjoyed, such as swimming and walking for exercise. She denied additional systemic symptoms such as fevers, rash, oral sores, dry eyes or dry mouth, or Raynaud's. And she had found that a heating pad and whirlpool tub were helpful in reducing her symptoms. Her past medical history included osteoporosis. Her malignancy screens, including a mammogram and colonoscopy, were normal and up to date. And she had taken Celebrex 100 milligrams daily without significant improvement in her symptoms. On physical exam, she was thin with a body mass index of 17. Her general physical exam was normal. On musculoskeletal exam, she had decreased grip strength bilaterally. She had bilateral shoulder pain with full external rotation and normal active and passive range of motion of her shoulders. She had synovitis, mild in both wrists as well as in her PIP joints, and synovitis of the left foot MTP joints. She had mild bony enlargement of the DIP joints. Her left hip internal rotation was limited to 5 degrees, and her right hip internal rotation was limited to a few degrees, and groin pain was elicited with flexion of that hip to 90 degrees. Her laboratory data included a mildly elevated platelet count, a high sedimentation rate of 90, and C-reactive protein of 64. Her liver and kidney tests were normal. Her primary care doctor had checked muscle enzymes, which were also normal. Lyme antibody testing was negative, ANA was negative, and her rheumatoid factor was slightly elevated at 17, just over the normal limit of 14. 7 months ago, she'd had labs checked, which had included a normal sedimentation rate and C-reactive protein. Her primary care doctor was concerned about an underlying malignancy given her weight loss and profound fatigue. A CT of the abdomen and pelvis was normal. A chest X-ray was also normal. At her first rheumatology visit, additional testing included a CCP antibody, which was high at 111. Her parvovirus serology was negative, and hepatitis B and C testing was negative. This is an image from her initial joint films showing intercarpal joint space narrowing, so narrowing of the bones within her wrist. She does not have erosions or apparent damage to other joints, and her foot x-rays were normal. So this patient also has rheumatoid arthritis. She presented with an inflammatory arthritis with prominent joint stiffness and did have synovitis on exam. She had systemic symptoms, including fatigue and weight loss, elevated inflammatory markers, a positive rheumatoid factor, and CCP antibodies. And she was started on methotrexate and prednisone and is improving. So what are treatment goals in rheumatoid arthritis? Well, goals are really twofold. So one is to decrease symptoms and improve the patient's daily function. The other is to reduce long-term joint damage. There is a group of patients who can have progressive joint damage and joint deformities despite minimal or no symptoms. Early treatment is really essential in patients with rheumatoid arthritis, ideally within 3 months of the onset of symptoms. And that treatment should include a disease-modifying anti-rheumatic drug. Methotrexate is the one that's most commonly used. Hydroxychloroquine, sulfasalazine, and leflunomide can also be used alone or in combination. This is a meta-analysis examining the long-term impact of early treatment of rheumatoid arthritis on radiographic progression. So in this meta-analysis, the average delay between the early DMARD group and delayed DMARD group was 9 months. In patients who were treated early, so in the early DMARD group, they had less X-ray damage over time. And this was shown in both cohort studies and in randomized controlled trials. So this is what we're trying to prevent, is progressive joint erosion and joint damage in rheumatoid arthritis. This shows one patient's interphalangeal joint over time, where in panel A, the joint is normal. Panel B, they're starting to develop an erosion at the margin of the joint, and then in panel C, there's a more severe erosion. And these changes can happen quickly and often within the first 2 to 3 years after the development of symptoms. So what are the treatment goals at primary care visits? It's important to refer to a rheumatologist early if rheumatoid arthritis or another inflammatory arthritis is suspected, so that the patient can be started on disease-modifying therapy as soon as possible. Try to avoid steroid use prior to the rheumatology evaluation, as the physical exam is very helpful diagnostically. If a patient is overweight, encouraging weight loss is helpful. Exercise is helpful for these patients in reducing their symptoms and maintaining function. If a patient has a flare with inflamed joints and fatigue, rest is also important. This does not mean that they should stay in bed all day, but they should balance their periods of activity with periods of rest, perhaps going to bed earlier each night and scheduling a rest period during the day. It's important that these patients quit smoking if they're smokers, as smokers with rheumatoid arthritis do worse than those who do not smoke. And reducing risk factors for cardiovascular disease is helpful, as rheumatoid arthritis increases the risk for cardiovascular disease. Rheumatoid arthritis is also a risk factor for osteoporosis, and many of these patients have taken steroids, so bone density testing is important as well. So the next patient is a 56-year-old man with hypertension and elevated cholesterol who developed acute joint pain and swelling. 1 month ago, he underwent a right knee arthroscopy for a meniscal tear. A few days prior to this surgery, his left knee became painful and swollen. So intraoperatively, he underwent a left knee arthrocentesis with aspiration of 50 milliliters of synovial fluid. This fluid was inflammatory with a white count of 13,000 and a neutrophil predominance. The synovial fluid was positive for monosodium urate crystals, and gram stain and cultures were negative. He was treated with a steroid injection with improvement. However, a few weeks later, his left knee swelling and pain recurred. This episode was treated with indomethacin, and he again had improvement. He had had a similar episode in his left knee 7 months previously, which had also been treated with a steroid injection. And he reported that 1.5 years ago, he had an episode of right ankle pain and swelling that felt similar. So this patient has gout. These are images from other patients with gout. On the left, this patient has severe inflammation of his first MTP joint, the classic location for gout. And on the right, this is a foot film from another one of my patients who has tophaceous gout. He has a classic gout finding of an erosion at the head of his left fifth metatarsal bone. The erosion has the appearance of a rat bite and has overhanging edges. This is a classic finding for gout. It's termed rat bite because it looks like a rat took a bite out of the bone. These are tophi in patients with tophaceous gout, and these are things that we like to try to prevent. A good place to look for these is on the pinnae of the ears. They're also commonly seen over joints that have been affected by gout flares. And with treatment, these can dissolve over time. So for my patient, he'd had multiple episodes of gout. It was crystal proven. So uric acid lowering therapy was indicated for him. He was started on allopurinol at a dose of 100 milligrams daily and then titrated up from there. 100 milligrams is the recommended starting dose for allopurinol. The reason for this is to try to reduce the incidence of more severe adverse effects, such as a Stevens-Johnson syndrome. The goal uric acid is less than 6. If a patient has renal insufficiency, febuxostat or Uloric is usually a better choice. The reason for this is that renal insufficiency increases the risk for adverse reactions to allopurinol. It's important to wait until after the acute gout flare is resolved before starting a uric acid lowering therapy, because these medications, if started during a flare, can make the flare worse and make it last longer. When starting uric acid lowering therapy, flares can occur. So for the first 6 months, or 3 to 6 months, it's recommended to also treat the patient with colchicine and NSAID or low-dose prednisone, depending on the individual patient. And if the patient has a flare, treat the flare, but also continue the uric acid lowering therapy. So what are treatment goals at each visit? It's important to reinforce appropriate medication use. As I've seen probably every combination where patients stop medicines or take the medications inappropriately. Uric acid lowering medications, once they're started, they're usually continued indefinitely. They should not be stopped during a flare, and a patient should not take extra during a flare. If a flare occurs, short-term treatment can be given with NSAIDs, colchicine, or prednisone. Avoid long-term use of these medications in gout if possible in order to minimize the risk for side effects. And avoid colchicine in patients with renal insufficiency. Due to decreased renal clearance, there's an increased risk for colchicine toxicity, including bone marrow suppression. This patient has a left knee effusion with pooling of synovial fluid in the suprapatellar pouch. So when a patient has a joint effusion, when do they need an arthrocentesis? If the effusion is new, an arthrocentesis is usually helpful. They should absolutely have an arthrocentesis if there's any concern for infection. So if they have a fever or if they've had recent surgery. Synovial fluid analysis is also very helpful and the only way to definitively diagnose gout or pseudogout. If a patient has a chronic infusion, such as a chronic knee infusion due to osteoarthritis, a steroid injection may be helpful in reducing symptoms. If the patient can't ambulate, they need further evaluation. If a patient has long-standing osteoarthritis of a joint and an effusion that is not warm or tender, they may not need an arthrocentesis. So on to some clinical pearls and back to uric acid. Gout begins as an episodic disease, so it's most helpful to check a uric acid when the arthritis is episodic. A uric acid level is generally not helpful for a slow onset or a chronic arthritis. The one exception to this is in patients with renal insufficiency, where gout can be polyarticular from its onset. Uric acid levels can be low during an acute attack of gout, so it's best to check the uric acid level after the acute episode has resolved. A definitive diagnosis of gout can only be made by arthrocentesis with documentation of monosodium urate crystals on synovial fluid exam. And asymptomatic hyperuricemia should not be treated. It's only treated if it is associated with episodes of gout. In a patient with hip pain, I always ask the patient to point to the location. They can mean anything from true groin pain, which is usually an indication of hip pathology, to lateral hip pain, which may be due to a bursitis, to buttock pain, or to low back pain. Raynaud's phenomenon is most common in young women. If new Raynaud's develops in an older patient, it's important to consider a systemic autoimmune disease or a malignancy. Another thing to determine is whether the patient has recently started taking a beta blocker, as these medications can cause Raynaud's. So this is classic Raynaud's with blanching of these 3 digits. The characteristic color changes in Raynaud's are initially white, then blue as cyanosis occurs, and then red as reperfusion occurs. Raynaud's typically occurs on cold exposure and is due to vasospasm in the arteries and small arterioles that go to the digits. It can also occur in the toes. Classic polymyalgia rheumatica often presents as a patient over age 60 with fatigue, shoulder and hip pain, and prominent stiffness. Inflammatory markers, sedimentation rate, C-reactive protein are helpful, but up to 20% of patients can have normal inflammatory markers. Anemia is common in PMR, and 30% of patients have an elevated alkaline phosphatase. If there are no symptoms of giant cell arteritis, such as headache, jaw claudication, or scalp tenderness, go ahead and start prednisone at a dose between 10 and 20 milligrams daily, depending on the patient's size and the severity of symptoms. Prednisone treatment can be helpful diagnostically, as patients with PMR have resolution of their symptoms within days. In a patient with persistent Achilles tendonitis, consider psoriatic arthritis or a spondyloarthropathy. As an example, I saw a 50-year-old woman with right then left Achilles tendonitis that had been persistent for 2.5 years. She also had bilateral knee pain with normal x-rays. Prior treatment had been extensive and included boots, NSAIDs, shockwave treatment, platelet-rich plasma injections. She'd undergone multiple MRIs, both of her ankles and knees. She'd seen a podiatrist and 2 orthopedic surgeons, and she'd been treated with Synvisc and Euflexant injections in her knees, all without significant improvement in her symptoms. So she had a spondyloarthropathy. Once she started sulfasalazine, her symptoms began to improve, and she's been doing well for the past 4 years without recurrence of Achilles tendonitis or knee pain. It's helpful to examine the nails when considering psoriatic arthritis in a patient. One finding that can be seen is onycholysis, where there's separation of the nail from the nail bed and this whitish discoloration. Another finding in psoriasis is nail pitting, and one or both of these findings are often seen in patients who have psoriatic arthritis. And it's common to see these findings in the digit where they have arthritis. If they have arthritis, especially in a DIP joint, the nail will often be affected as well. Sedimentation rate increases with age. A normal sedimentation rate for a man is his age divided by 2, and for a woman is her age plus 10 divided by 2. Sedimentation rate can also be increased by anemia and renal insufficiency. This is an image of a patient with rheumatoid arthritis with synovitis at the MCP joints. However, RA at first glance is not always RA. As an example, this is a patient with lupus and Jacquard arthropathy. So these deformities are due to ligament laxity rather than to disease at the joints themselves. On X-ray, there are no erosions, and these changes are reducible. So if you physically move, you can physically move the patient's hand back into a normal position. If a patient with rheumatoid arthritis has deformities like this, it's not possible to move their hand back into a normal position. An X-ray would show joint damage and usually erosions. This is another patient that I saw who came in with progressively worsening joint pain and stiffness. Across the room, at first glance, her hands look like those of someone with rheumatoid arthritis. She had enlargement of her MCP joints. But on physical exam, she did not have synovitis, and what she did have was a chronic arthropathy due to hemochromatosis. She has a classic finding of hook-like osteophytes on the medial aspect of her MCP joints. Again, there are no erosions in these joints. Patients with hemochromatosis and arthropathy are also at increased risk for acute episodes of pseudogout. So thank you very much for your attention.